Welcome everyone to Creating a Family, talk about infertility. Today we're going to be talking about an introduction to female fertility. Understanding fertility is a very good introduction to understanding infertility. Our expert today is Dr. Julie Lamb. She is a board-certified reproductive endocrinologist and infertility specialist at Pacific NW Fertility in Seattle, and she serves as a clinical faculty at the University of Washington. She directs the REI training of OBGYN residence physicians and is the director of the Center for Fertility Preservation at Pacific NW Fertility. Welcome, Dr. Lamb. Thank you for joining us today to talk about a topic that is of great importance to all of us, female fertility. Let's just jump in there. Let's start with one of the most basic things that we really must understand, and that is the menstrual cycle. So let's start with, how does the menstrual cycle work in a healthy woman who is not at this point experiencing any infertility issues?
Well, thanks for having me, Dawn. And certainly understanding the menstrual cycle is something that, a lot of us grow up not really understanding. I see physicians that don't really understand the menstrual cycle. So it's something that's kind of complicated.
It is very complicated.
So the basic menstrual cycle occurs like once a month. So I often hear patients say, oh, well, my cycle's not very regular. But actually, if it comes between 25 and 35 days and you don't miss months, then that would be considered a regular menstrual cycle. And the menstrual cycle is broken into two parts. The first part is growing the follicle, which houses the little egg. And the second part is after the release of the egg, sustaining the lining until a pregnancy could take place, until the ovary could sustain the pregnancy in case the egg is fertilized and implants in the uterus. And if that doesn't happen, then the period comes and the lining sheds. So a lot of my patients say, oh, well, I know I'm releasing the egg, or, I don't think I'm releasing my egg. But if you're having a regular menstrual cycle, then we know that most likely an egg is being released every month.
So what part of our body tells our ovaries to start maturing an egg? How does that happen?
Yeah, so it's actually the brain, a part of the brain called the pituitary that makes a hormone called follicle stimulating hormone that recruits a follicle on the ovary to grow and matures the little egg inside. And then that same part of the brain that causes ovulation to release the egg into the fallopian tube where it could be fertilized.
So what tells our body to shed the uterine lining if an embryo does not implant?
So if the embryo doesn't implant, then the progesterone that the ovary is making after the egg is released withdraws and decreases, and that decrease is what causes that lining to shed. So if there's a pregnancy there, then those hormones are supported, and that pregnancy is the progesterone is produced for longer, and then we don't see the lining shed. And that's how a patient would know to check a pregnancy test, by not giving that period.
All right. So let's then back up and also talk about the basics of conception. You mentioned that our pituitary has released FSH, and it has told our ovaries to mature an egg. Usually this is one egg that is matured and then released. And that egg then goes to is sucked the right word? It's kind of sucked into the fallopian tube. It is,
picked up.
And so it is
picked up by the fallopian tube.
All right. So now take us from there about how a conception would happen.
So we want sperm waiting for the egg. So a woman needs to time intercourse with a partner or get sperm there waiting for that egg to release. So the sperm is already up in the fallopian tube to meet that egg. And if the fertilization occurs, then the egg continues to travel down into the uterus and will hopefully implant in the lining of the uterus. And as it implants, it starts making a hormone called HCG, or the hormone of pregnancy. It's that one we test in the blood 2 weeks later. And that is what supports the corpus luteum, which is the little follicle where the egg released from, to continue to make progesterone. So making that progesterone sustains the pregnancy and keeps that menstrual cycle from occurring in the setting of a pregnancy. Yeah, it's pretty amazing.
It is amazing. It's absolutely, human conception It's absolutely, I mean, it's a miracle any of us, that anybody gets pregnant. It's just, if you think about all the
Right.
possibilities that things that could go wrong.
Certainly.
All right, so that's the basics of fertility in a healthy woman. So let's talk about infertility. First of all, how is infertility defined?
So, infertility is a medical condition, and it's a unique medical condition because it actually depends on two people, not a single individual. And it's defined as the inability of a couple to conceive after 12 months of regular intercourse without the use of contraception in a woman that's less than 35. And it's defined by 6 months of regular intercourse without the use of contraception in a woman that's greater than 35 or 35 years or older.
And let me ask a question. Is that timed intercourse? So if somebody is, you had mentioned before, and that it's important to time sexual intercourse. You want the sperm to be present when the egg, so that it arrives in the fallopian tubes. So we call that timed intercourse.
Right.
So is the 12-month of trying with timed intercourse, or if you're timing your intercourse and you've gone 5 months and you're 30, should you see a doctor because the 12 months is actually just intercourse any time of the month
Right.
you're feeling in the mood?
Yes, so certainly it requires much more regular intercourse. If you're not timing intercourse, or if you're just having sex once a month, then the fertility rates will be lower. You know, if somebody's having
Mhm.
difficulty having intercourse, then certainly want to see them sooner than a year. Or if someone's not having regular menstrual cycles, that's more concerning and also a reason to see a fertility specialist. But really, infertility is defined as either regular intercourse or timing intercourse for
Gotcha.
for that
Okay.
year.
But if a woman is not ovulating, is not having regular periods, or even if she's having periods but they're highly irregular, at that point it makes sense to go see a specialist sooner.
Right,
Okay,
right.
obviously,
I think,
good.
yeah, patients should never hesitate to reach out and talk to a specialist if they're worried.
No, yeah,
Mhm.
exactly. Or if they think they have reason to be worried.
Yeah,
So,
right.
how common is infertility as you just defined it?
So we consider it pretty common, right? So 1 in 10, or even some studies say 1 in 8 couples will experience difficulty conceiving. Certainly, it depends on the age at which you start trying to conceive. So I think one of the common misconceptions is that infertility is more common, but really we're just waiting as a population. We're waiting longer to conceive. A generation ago, we had babies in our 20s, but now we're
Hmm.
usually, often women wait till their mid to late 30s. And certainly
Hmm.
the prevalence of, or the incidence of difficulty conceiving increases with age.
Hmm. All right, we mentioned what conditions would warrant an immediate infertility workup without waiting the recommended amount of time. We mentioned irregular periods, or absence of periods. So, what are some other conditions that would warrant not waiting the recommended 12 months if you're under 35, and 35 and older, 6 months?
So lots of different things I encourage women to reach out to a fertility specialist for. So if you have severe endometriosis, which is when the lining of the uterus grows outside the uterus, it's often diagnosed by surgery, but sometimes an early sign of it is just really painful periods. So we encourage those patients to reach out sooner. If you've had surgery on an ovary or tubes or on your female anatomy that could have damaged part of it, we want you to consider reaching out sooner. If you know your partner has low sperm, that would be a reason to reach out sooner. Or if you have any abnormalities, known abnormalities with the uterus or tubes or ovaries, certainly don't hesitate to reach out sooner.
Yeah, a lot of times people don't know,
Right.
but if they do, uh,
Mhm.
excellent.
Yeah, or just like known fibroids, or yeah, something that could potentially cause fertility. Getting checked out and being reassured that everything's healthy and normal can be really helpful to women, especially.
Okay. So we have defined infertility, but Another problem that falls in this same category would be recurrent pregnancy loss, not the inability. Often these women are able to become pregnant, but are not able to stay pregnant. So, at what point is miscarriage, which we know is very common, at what point does it reach the level of concern that one should seek treatment?
Again, anytime that you're worried, I think it's okay to reach out. Miscarriage is pretty common, and it also increases with age. So you're still more likely to have a healthy pregnancy than any other option, any other outcome. But reoccurrent miscarriage is defined as like just the inability to carry a pregnancy to term, and we consider it and start testing for it after 2 to 3 miscarriages.
So if you were concerned,
Yeah.
but medically, the recommendation is 2 or more
Right.
miscarriages.
Right. And the recommendation really is 3 or more miscarriages. But after 2, patients are so heartbroken that we start with
Mhm.
the investigation then.
hmm And what type of specialists do you recommend a woman go to who has had 2 or 3 miscarriages?
Right. So this is also with a reproductive endocrinologist or a fertility specialist. This, an inability to carry a pregnancy is part of that infertility definition, and also would see a fertility specialist.
Okay, right. And a fertility specialist is a reproductive endocrinologist.
Yes.
And what type of training does a reproductive endocrinologist have that is distinct from the training that an OBGYN has?
Yes, so we start out very similarly. We all do 4 years of medical school and then 4 years of obstetrical and gynecological surgery as residents. And then the reproductive endocrinologist has a 3-year subspecialty fellowship training in fertility.
Okay. What percentage of infertility is caused by the female partner and then by the male partner, or a combination of the two?
Yes, so fertility problems are about a third of the time male factors, so related to low sperm for a variety of different reasons. And about a third of the time they're female, like either ovulation dysfunction or problems with the tubes or endometriosis or difficulty having intercourse are female related. And then the final third of the time, we call it unexplained, and it can be related to like multiple factors and sometimes factors that we don't have a diagnosis for or don't have a way to test.
Yeah, that's so frustrating because I think not having a cause is really hard.
Yeah,
It plays on your mind.
it's often that everything looks healthy and normal, and we're still probably something that we don't know how to test yet that can happen in the
Mhm.
tubes or microscopically that we can't see.
Yeah, exactly.
It's hard for patients to hear that everything looks healthy and normal. Then they're like, why isn't it working? It's so frustrating.
Yeah, no, you're exactly right. It is hard. Uh, Sometimes it's the hardest because you don't have a cause. You don't have
Mhm.
you have nothing to focus on. Yeah, and it's very hard for the patients. All right, what are some of the common reasons that women do not ovulate? Because a failure to
Mhm.
ovulate is obviously a common cause of infertility.
Yeah.
So, what are some of the medical conditions that would cause a woman to not ovulate?
So there's a variety of conditions that can cause a woman to miss her periods or to not ovulate. That's the first sign that someone's not ovulating, if they're missing that menstrual cycle every month. One of the most common ones that I often see is polycystic ovarian syndrome, which is abbreviated PCOS, and often presents when a woman's trying to conceive and comes off the birth control pill and just doesn't have normal periods or regular cycles. And so that's probably the most common, but other endocrine abnormalities can also cause difficulty ovulating, such as thyroid abnormalities, prolactin abnormalities. All of this gets tested in that initial infertility workup. And then another common is body weight. So a high body weight or a very low body weight can also affect ovulation.
And why is that? Why does body weight impact ovulation?
Yeah, so it just affects the hormone axes. So at a very low body weight, you just don't have the hormones that the brain isn't making, the hormones to recruit the follicle and release the egg. And that at really high body weights, that extra fat tissue makes estrogen, and that interferes with the axis sometimes to release the egg. So that hormone axis is affected.
So on both extremes,
Right.
low body weight, the pituitary is not is not telling the ovary to produce the egg or to mature the egg, and then excess body weight, it would be the estrogen, which would be interfering with the reception of the hormone for maturing the egg.
You're right.
Okay. All right. You mentioned cause for an initial workup. So let's talk about what is a part of the initial workup for a woman who is presenting as having infertile. She if she, depending on her age, 12 months or 6 months, she has not conceived. So what are some of the aspects? What are some of the components of this initial workup that a woman should be receiving?
Yeah, so when you meet with your fertility specialist, you kind of walk through the different systems and talk about the testing. And, one of the first things and the easiest things to test is the sperm. So checking the seminal fluid, or we call it a seminal fluid analysis. Checking that sperm count is one of the first steps, and it's really the only step that the male partner contributes to. The other piece of it is blood tests for the female, kind of those tests we talked about that are important on ovulation, the thyroid and the prolactin, and also looking at the ovarian reserve, or what we call the egg supply, which is an anti-Müllerian hormone, and the follicle-stimulating hormone and estradiol levels. And those last two are done at cycle-specific times, so at the beginning of the menstrual cycle, where they can be best evaluated.
Are those blood tests?
Yeah, all those
you just mentioned?
all those are blood tests. And they can all be done with one poke, one stick, if you do it at the beginning of the menstrual cycle. Oftentimes, when we're doing a fertility evaluation, we check other blood tests as well, just kind of preparing for pregnancy, such as blood type and titers to different, chicken pox and rubella, making sure you're immune, and just your general health status. So there can be other blood tests added to that. And then really the last two components of the infertility evaluation are a pelvic ultrasound. So looking at the uterus, tubes, and ovaries with an ultrasound. It's usually done transvaginally, and it helps us understand if there's anything in the way of a pregnancy, like a fibroid or a polyp, or if endometriosis might be a more likely diagnosis. If we see something like an endometrioma or a cyst on the ovary, that can be a sign of other diseases or other things that can contribute to infertility. And then the final thing that we're looking at when we do that transvaginal ultrasound is the ovarian reserve with an antral follicle count. We can see those resting follicles and get a little window into a woman's fertility and a woman's ovarian reserve by counting those at a certain stage of the cycle.
So what would be considered normal? When you're counting, what's considered normal?
Yeah, we consider anything that's above 10 to 12 range combined between the two ovaries. We would consider that normal. Doesn't tell us if a woman can get pregnant or not, but it does give us a little picture into those blood tests, and what, if I see a normal antral follicle count, then those blood tests are more likely to be also normal.
Okay.
The final thing for a fertility workup is that hysterosalpingogram, which is the picture of the tubes, and knowing that those tubes are open and evaluating that uterine cavity is just that final piece of the fertility evaluation.
And how is that test run?
That test is a fluoroscopic, like a picture of the uterus. We put a little tiny bit of dye inside the uterus and take an X-ray picture. It can be a little bit crampy anytime you put anything in the uterus, and then with high pressure, push it out the tube. It doesn't feel very good, so we encourage women to take ibuprofen before that test. But it gives us a better indication about a healthy uterine cavity where the embryo would implant, and tells us that if the tubes are open, and that's an important component in achieving pregnancy.
So is all that usually done at the first or second, one of the first part of the initial workup?
Yes, yeah, all of that's part of that initial workup.
Okay. I'm assuming medical history is probably one of the first things that's done as well. What things are you asking about in a medical history that would be relevant to helping diagnose someone as infertile?
Yeah, that's a great question, Dawn. So that's actually where we start. Like, that's one of the most important parts is before we even talk about all this testing, we go through the medical history of both the patient and her partner. And we talk to them about their menstrual cycles. I want to know if they ever miss a month. I want to know if her periods are painful. I want to know if she has pain with intercourse. I want to know if there's any medical history, like thyroid disease or things like that could impact fertility. I ask quite a bit about male factor fertility, like did he have any surgeries on his testicle, or has he had a hernia repair, or something that could have caused the sperm count to be low. And then we even ask about family history. So I want to know the age that the woman's mother last conceived and the age of menopause. I'm much more concerned if her mother went through menopause early in her 30s or early 40s. So it's a lot of information from the history. The medical history can be really important in a fertility evaluation.
Mm-hmm. Mm-hmm. What about sexually transmitted diseases?
Yeah, that's a great example. You want to know if there's any history of chlamydia or gonorrhea, especially because it can affect the tubal factor fertility, can cause the tubes to be less functional.
Mm-hmm. Okay. So all of that would be solicited from just talking with the patient, and hopefully they have this information or know this information.
Yeah, most people know this kind of information.
Yeah. All right. So now let's talk about the workup for recurrent pregnancy loss. So a woman has had 2 or 3 miscarriages. First of all, is it important that the miscarriages be sequential, or if they are interrupted by either a long period where they have not been trying or a pregnancy? To qualify as recurrent pregnancy loss, do they need to happen sequentially?
It actually just doesn't matter anytime. We even include any kind of clinical pregnancy, wherever it happens, counts. So even just a pregnancy test that's positive before we see an intrauterine pregnancy by ultrasound, we would include that as a biochemical and count that as a pregnancy when we're looking at recurrent pregnancy loss. So it could be that you had one of those and then you had a healthy pregnancy to term and had a baby, and then you had a second miscarriage after the delivery. We would count that as two miscarriages. Doesn't have to be all 3 in a row. It can be separate.
Okay. So a patient comes to you with having had 2 or 3 miscarriages, pregnancy losses. What is a part of that workup?
So it actually is pretty similar to the fertility workup. We start with that same history and physical examination and ultrasound. And an important part of the history that I'm eliciting is like any history of autoimmune diseases or any history of blood clots, or did your mom or anyone in your family have recurrent pregnancy loss? I'm screening for other things that can cause miscarriage. Like, has anyone ever, have you ever had any workup or any ultrasounds or that have shown a uterine anomaly or something with your uterus that can cause an abnormality? And so that history, again, just like in the infertility workup, is also important with recurrent pregnancy loss. And some of the testing we also do is similar. So those hormone evaluations are also really important, even a couple more that we do. And then a uterine cavity evaluation. So often starting with that same hysterosalpingogram or a test that's called the saline sonogram that helps, a special ultrasound that gives us a really good look at the inside of the uterus to making sure there's nothing inside the uterus that could be causing a miscarriage.
Okay. Let me pause for a moment and remind you that this show, as well as all the resources brought to you by Creating a Family, could not and would not happen without the generous support of organizations who believe in our mission of providing you unbiased, medically accurate information. One such partner is Walgreens and Alliance RX Walgreens Prime. They provide specialized fertility pharmacy services through an experienced care team available 24/7, devoted to helping patients achieve successful outcomes. They understand the importance of timing and the need for personalized treatment and are committed to compassionate care and support throughout a patient's journey to have a family. Another partner is Cryos International Sperm and Egg Bank. They are dedicated to providing a wide selection of high quality, extensively screened frozen donor sperm and egg from all races, ethnicity, and phenotypes for both home insemination as well as fertility treatment. Cryos International is the world's largest sperm bank and the first freestanding independent egg bank in the United States, helping to provide the gift of a family. All right, let's talk now about treatment options for infertility. I think people immediately assume when they hear infertility treatment, they immediately go to thinking that IVF is the only option. So let's back up a bit here. Let's understand some of the basics. So when somebody first is going to be treated for infertility, I know obviously it's going to depend on the cause, but what are the options that you as a reproductive endocrinologist look at?
So once the cause of infertility is identified, therapy is initially aimed at correcting the reversible causes and then overcoming the irreversible causes, so we can implement kind of a strategy to treat their fertility. So we start with simple things like lifestyle modification to improve fertility. If they're smoking, we have them stop. We have them look at their alcohol consumption, look at their weight. We make sure they're appropriately timing intercourse and make sure they're ovulating at the right time and help them predict when they're ovulating, sometimes with the use of ultrasound or an ovulation predictor kit. So some of those initial strategies can be really helpful for couples.
Okay.
Yeah, and then there's other therapeutic interventions, and those main two with those are the intrauterine insemination and then the IVF, like you mentioned.
All right. You have said a couple of things. One, you can help if a woman is not ovulating. One of the things you try to do is help her ovulate.
Right.
What are the approaches for helping someone ovulate?
Yeah, so we call that ovulation induction, and we not only use lifestyle modification, so we make sure that there's not a hormone that's causing it or obesity that's causing it, and then we help them ovulate with medication, which is usually an oral ovulation induction agent, such as Clomid or Letrozole, Femara.
Okay, and they can, how effective are either letrozole or clomiphene citrate for inducing ovulation or helping a woman who is not ovulating to ovulate?
That's a great question. I guess it would depend on the ideology of the anovulation. So the reason why the woman's not ovulating, but usually it's pretty effective. I think probably 9 times out of 10, it will help a woman release an egg on a more regular basis.
All right. So what are the pregnancy rates then for treatment through oral medications, such as either letrozole or clomiphene citrate?
Yeah, so it certainly depends on the age of the patient. So when a patient's not releasing an egg and you help them release their egg and they're in their 20s, then the pregnancy rates can be as high as 15 to 20% per month. But by the time a patient's 40, it's as low as 5% per month. So there's a lot of variability. It's mainly based on age and the cause of the fertility issue.
As is natural conception as well.
Right,
really,
right. Right. It really brings it up to that level of natural conception, what it should be, because you're not really fixing you're fixing the problem of not ovulating and releasing the egg, but it doesn't really improve on levels of natural conception.
Okay. And now you also mentioned IUIs, intrauterine insemination. So tell us about that and what does that mean? What is involved and how successful is it?
So that is the process of washing the sperm from a partner or from a sperm donor and putting it inside the uterus. So threading it through the cervix with the use of a speculum and placing it near the top of the uterine cavity. It kind of feels to a patient kind of like a pap smear is how I describe it. But it's specifically helpful in cases where there's low sperm counts or a couple is unable to have intercourse, or in a woman who has either a female partner or is single and just needs sperm put close to the egg. And the success rates, Dawn, are very similar to natural fertility, right? So it depends on the age of the woman and what other kind of fertility factors are impacting things. But the success rate really should be looked at as like a group of cycles. So it's per cycle, it might not be as high as any of us want it to be, but someone who's in her early 30s, more than half of patients would be pregnant over a 3 to 4 cycle period of time.
So that brings us to a question that we probably should have asked at the very beginning, which is, what is the natural fertility rate for a couple with no fertility issues?
Right. So I think that, when you're young, you think every month you have such a good chance of conceiving, but I think it's a common misconception how difficult, how many things have to happen every month to conceive. So even when you're in your 20s, the chance of pregnancy every month is only about 15 to 20%.
And that's with timed, that's with timed intervals, correct?
Right. So not every egg causes a baby, even when you're young and healthy. And those eggs are less efficient as we age. So the quality and the quantity decrease with age. And by 40, 1 in 20 eggs makes a baby. So it changes a lot in between 35 and 40.
The decrease is certainly increasing at that point. The decrease in infertility.
Right.
Or decreasing of fertility, the increasing of infertility. All right, so we've talked about IUI. Is that the only form of artificial insemination is an IUI, or are there other forms that can be used as well?
That's kind of it. Are you thinking about something specific? I guess it can either be partner sperm or donor sperm. It doesn't have to be partner sperm.
I was thinking intracervical versus IUI.
Oh, right. Some of my patients do intercervical or do that at home. We find it to be just more successful putting it all the way inside the uterus. But yeah, some people will not process the sperm and put it in the vagina or in the cervix.
Either at home or in a doctor's office, yeah. Okay. So we've talked about natural conception rates, and then we've talked about using oral medications, and IUIs and how successful those are. So let's talk about IVF now, in vitro fertilization. So what is that process, and who do you recommend it for?
So it's really a case-by-case basis, but patients, the IVF process is the process of growing and maturing the follicles inside of a woman's body in order to take out more than one egg. So because not every egg causes a pregnancy, if we're going to grow and mature the eggs, we want more than one to give a patient the best chance of success. So the entire process kind of evolves around that goal of maturing eggs inside the woman's body. And we do that using that same hormone that we check when we're looking for ovarian reserve testing. So that follicle stimulating hormone is used, and it's a hormone that's like insulin. It can't be injected, or it can't be swallowed. We have to inject it. So it's a series of injections on an average of kind of 10 to 12 days. And during that time, we watch the growth of the ovaries and the eggs. And then we go in and with a tiny little needle, like we would use to draw blood, but it goes through the top of the vagina, and we aspirate the follicles, and with it comes the egg. So this treatment of fertilizing these eggs outside of the body is really helpful for patients that either have severe male factor, so very low sperm count, because it allows us to fertilize each egg individually with a single sperm, so it doesn't rely on the millions of sperm that would be important for natural conception. It also allows us to bypass tubal factor fertility, so it's taking the egg outside the body and bypassing the tube. And it's also helpful for either unexplained or age-related fertility, because it helps us find the best egg, because we can get a number of eggs in a given month. So those are the main groups of patients that this is helpful for.
And how can you find, okay, so you have collected a number of eggs. How can you determine which is the best egg?
So the embryologist will look at the eggs under the microscope, and they'll fertilize the eggs, and then we watch them grow to day 5. And the ones that survive and make day 5, day 6 embryos have the best chance of creating a baby. So we can actually do more testing now, especially with increasing age. We can take some of those cells that would become the placenta, and we can test them for genetics. We can look at the chromosomal complement, make sure it's normal. And that's the thing that's affected the most by age. So when we're 35, about half of our eggs are abnormal already. And by 40, it approaches 80%. So testing those beautiful embryos under the microscope really helps us select the one that's most likely to cause a pregnancy.
All right. So the process for IVF, walk us through the medications that you would use throughout the IVF process.
Yeah, so the medications we use, there's a bunch of different ones, and it can be overwhelming for a new nurse and certainly overwhelming for patients. But in general, it's a series of injections that helps the eggs to grow and then prevents them from being released early. And then there's a final medication that we call it the trigger medication, and it causes that final stage of maturity where it releases from the wall of the egg and would eventually release from the follicle. And before that happens, we go in and get the egg. So that medication is called a trigger medication. There's different types and different protocols that can be a challenge for patients and for team members.
And how do you decide which protocol to use?
We use a number. It's just very individualized per patient, but we use a number of different protocols. And the main difference is a kind of a high responder, a low responder. If we expect a patient to grow a lot of eggs, we're going to use a little bit different protocol than somebody we don't expect to grow very many eggs. And those protocol choices are sometimes made by those egg supply tests, but also the age of the patient is also a big factor.
Mm-hmm. Because you would expect older patients to not be producing as many eggs,
right.
I would assume.
You're right. Or just we want to be more aggressive because we know it takes more eggs to find one that will make a baby in an older patient.
And by stimulating the ovaries, how do you know that you're not going to? Are more eggs the better? Is what I'm trying to ask. Is there a limit as to how many you want to stimulate? If you're not sure how many you're going to get, then is more always better?
Yeah, more isn't always better, and especially in my younger patients, they don't need as many to cause a pregnancy. So certainly we want each patient to have a few more than she needs, because if the process doesn't work, it's lovely to have something left over so that she doesn't have to grow or start the whole IVF process again if the cycle's not successful. It's nice to have something saved for either a second baby or a second attempt from a single IVF cycle. But a younger patient just needs fewer eggs in general to cause a pregnancy than a patient of a more advanced stage.
Okay, and what is the success rate for IVF?
So it depends, Dawn, on a lot of factors, mainly age, but it also depends on a patient's ovarian reserve and the efficiency of the process for them. So if we're looking at the equalizer is having a genetically normal or embryo, and that success rate, even though it's clinic dependent, averages between 60 and 70%. But there's plenty of patients that go through the whole process, especially at advanced age, and just can't get an embryo that's high quality and genetically normal. So the cycle statistics vary so much, and they can be one of the most confusing pieces for team members and for patients.
And they are so age dependent.
Right, and they're so age dependent.
Which is hard for patients to hear as well.
Well, let's move on to talking about treatment options for recurrent pregnancy loss. What options do we have for women who are struggling to stay pregnant?
So pregnancy loss is sometimes we consider it a good problem to have because you have more choices about how to get pregnant. So a patient that's easily becoming pregnant can try again, and we can support the pregnancy. There's some progesterone support, or we'll add aspirin after we do all this testing. We certainly start with all the treatments for any underlying condition that can cause a recurrent pregnancy loss. So if there's a septum or a uterine anomaly or something in the uterus that's in the way of a pregnancy, we address that first. Or a hormonal problem, we fix that first. If there's a thyroid disease, we address that. All those things are really crucial for recurrent pregnancy loss. But if a patient's going to go ahead and try on their own, that's when we'll consider adding to the progesterone and the aspirin, a baby aspirin.
And how is a baby aspirin helpful in the treatment of recurrent pregnancy loss?
So there's a lot that we don't know, and we probably have to treat quite a few patients with a baby aspirin to help one patient. But there's some data that says that there's some potential clotting factors that can cause recurrent pregnancy loss. So a baby aspirin treats some of the ones that we know about, but it also treats some of the ones that we might not know about or there isn't a diagnostic test for yet. So because it's very inexpensive and it doesn't do any harm, that's often added to a protocol for a patient that has a recurrent pregnancy loss history.
Okay, what about progesterone? How is that effective in preventing pregnancy loss?
So progesterone just makes sure we're basically not low. As we age, progesterone can decrease, and in some patient populations, they could have a low progesterone. So sometimes when a patient's miscarrying, we'll add progesterone with that positive pregnancy test to support the pregnancy until the pregnancy can take over and the placenta can make the progesterone. Kind of supports that ovarian function.
And how is the progesterone administered?
It varies by provider. We usually give it vaginally. We have a patient has fewer systemic effects or side effects if you insert the tablet vaginally, but it can also be given intramuscularly or taken orally.
Okay, so in any number of ways it can be used to support a pregnancy. What are the success rates? What can we tell women as far as their odds of if they've had 2 or 3 pregnancy losses? What are their odds of them being able to carry a pregnancy to term?
So especially after all the testing's been done and anything's been corrected, I find it really helpful to encourage patients that they're still more likely to have a healthy pregnancy than any other outcome. So these patients get so discouraged, but every time they get a positive pregnancy test, that pregnancy is still more likely to become a baby, a healthy baby, than any other outcome. Certainly, it's still possible to miscarry, but encouraging them and telling them that the chances of a successful pregnancy is still quite high.
Mm-hmm. Is it age dependent as well?
Yes, certainly age dependent.
Success rate?
Right. Certainly age dependent. And in fact, sometimes we do, we didn't talk about this when we were talking about IVF, but especially with advancing age, miscarriages are more common. So one of the treatments or one of the uses of IVF is this process of growing eggs and then testing embryos and finding that genetically healthy embryo to implant will decrease the miscarriage rate and decrease recurrent loss in these patients of advanced age.
Because the primary reason that they're miscarrying is because there's a chromosomal abnormality.
Exactly.
Mm-hmm. So what is the treatment of protocol, or what can you tell patients who are losing pregnancies in the second trimester? Is it different from what pregnancy loss in the first trimester?
Yes, it is different, and the workup is a little bit different. It's also much less common, luckily, because that's very hard diagnosis. Mm-hmm. So their workup is similar, mm-hmm. but a little bit more involved. And oftentimes we have those patients see a maternal fetal medicine specialist in addition to that fertility specialist, and we work together to try to not let that happen again.
What are the primary causes of second trimester pregnancy loss?
So one of the still common causes is that chromosomal abnormality, but also structural abnormalities, problems with the uterus. So a septum or a big fibroid in the uterus can cause later losses, as well as incontinent cervix. So cervical shortening or preterm delivery, kind of things that can cause preterm delivery, surgery on your cervix. And so there's some things that they do in the second trimester with a maternal fetal medicine specialist to try to prevent that, and monitoring that cervical length and administering higher doses of progesterone in that second trimester. Other common causes, I think there's a lot of unexplained causes. And then we also look for some of the clotting disorders, such as like some of those clotting disorders that we kind of talked about earlier. We look for those as well.
Also in the
yeah.
And these are more common in the second trimester losses.
Yes, correct.
Okay. We've talked about the infertility workup for cisgendered women, but let's also talk about the infertility workup and how it might differ for any of the members of the LGBTQ plus community. Just briefly, how would your initial approach differ, depending on if the patient is either lesbian or bisexual or
Right.
transgender or whatever, however they're presenting.
Right. So it's such a different conversation because often these patients aren't infertile. They just don't have sperm in their family. So it's a little bit less about infertility. They're not as anxious about being there, I find. They've, been planning on seeing a fertility specialist to achieve pregnancy because they don't have sperm in their family sometimes. So, and the workup's a little bit different. If somebody's young and just trying to achieve pregnancy for the first time and doesn't have the diagnosis of infertility because they haven't been able to try for 12 months because they don't have sperm in their family, then they don't meet that criteria for infertility. And so it's a discussion with the patient. Certainly when you're going to pay to put sperm there and go through the process of seeing a doctor to get pregnant, we don't want to miss anything. So we offer those same tests, those same workups, but sometimes we'll try some simple inseminations before we do some of the more complicated testing, because we don't assume that there's necessarily going to be a problem in achieving pregnancy. And we often see, really high success rates. But that being said, if the patient's of advanced age, that fertility window is smaller, especially if they're over 35, then we still often start with those same tests we talked about, the vaginal ultrasound, the hormone testing, the tube test, and making sure everything's healthy and normal before we start. Just because it can be so disappointing to try with a doctor for a while and then find out you have a problem. So it's just kind of a very robust conversation with patients, and some feel very strongly one way or the other, and it's a real personal decision what testing to do initially and what to wait till later.
And we are seeing just in our community that, even 5-10 years ago, that our lesbian couples our patients were waiting until they were older, but now they seem to be, at least we're seeing that patients are coming in, or lesbians are coming in at a younger age, so they're having less fertility issues.
Yeah, it's really great when somebody can get pregnant really quickly and easily. It makes me so happy.
Yeah, it makes them happy too. Let's talk a bit about just your transgender patients. Again, they may or may not have fertility issues. So how is the initial workup? How might it differ from your transgender patients?
So we see a variety of transgender patients at all points in time with the transition. Patients will come in free sperm before they transition to female, or they'll come in free eggs before they transition to male. So there's a lot of variety of fertility preservation options that we offer these patients as they consider transitioning. And then certainly even after the transition, we help them achieve pregnancy through a variety of treatment options related to either sperm donor or egg donor, or have a partner who carries, or a friend who carries, or friend who donates sperm. There's lots of ways to make beautiful families.
Excellent. Well, thank you so much, Dr. Julie Lamb, for talking with us today about Female Fertility 101. Let me remind you to keep in mind that this information given in this interview is general advice. To understand how it applies to your specific situation, you need to work with your infertility professional. Also, the views expressed in this show are those of the guests and do not necessarily reflect the position of creating a family, our partners, or our underwriters. Thank you for joining us today, and I will see you next week.